Hey there, it's Dr. Scott MacLean. We'll be talking about the Piezotome cube. And this cube allows me to do lateral sinus lifts. And let's have a look at what we're going to do. So I purchased this from salvin.com. And again, it's a fantastic tool. Now, I advise you to take a course like Michael Pico's course, for instance. Fabulous guy, fabulous teacher. And so I'd suggest you do that before you start to try this. So we'll be placing an implant in this area eventually. And if you notice that when we're using the DTX Studio implant software, we can see there's a deficiency in the bone. So looking at this, the patient needs to have 2 implants done. And so one in the anterior, one in the posterior behind the premolar. The anterior implant does not need a sinus lift. It needs a guided implant. But the posterior, we'll see if we do the planning, we can see that it needs to have some bone added. So we want to find out what the residual bone height is. So here it's good. Over here we have to add some bone and then place the implant in a delayed approach. So anchor pins are going to be used as guides on this case. So since we have roots everywhere, we want to make sure we're not going to hit a root. So as we go in, we can be very careful and be very exact about how high and how positioned mesial distally this guided approach would be. So looking at this, we can see that the implant would be placed in this position, and there's just not enough bone to do this. So we have a good spot, but sometimes the tighter the spot, the more difficult it is to do the bone grafting. So if we look at this, we can see there's one pin here. And if we look at the other pin, this gives us an approach to know exactly where we're going to go when we go into the sinus. We'll look at this residual bone height and plan this case. Now on the anterior implant, it's a premolar. We can see we have lots of bone, but it's tight. And so we want to make sure we get this implant exactly where it needs to go. So we'll be using a guided approach, and we'll show you the guide in just 1 minute. But we're going to modify the guide and do that. Now we do have to wait 5 months to place the second implant, but let's have a look at the residual bone height, the RBH. So the RBH in this one is pretty tight, and this allows us to know that we need to do a sinus lift. So the RBH is 2.3, which is just not enough bone to hold the implant, and so we have to add bone. So the question is always where you're going to get the bone. The patient always wants to know that because they don't necessarily want to get the bone out of themselves. Here's the guide. So this is a template. You can see that in the anterior we've planned the implant. In the posterior we've planned where the grafting is going to be started. So we're going to use this tool, the piezotome, to enter into the sinus. So I'll mark the lingual ring, and this is going to be my incision line. So as I flap this, I don't have to flap the palatal at all. So I'll come across that lingual line. This will do a few things. It'll beef the soft tissues up on the buccal, but it also keeps this out of the guide's way. So when we put this in, we don't have to worry about making sure that the tissue is in the way. So I'll use a molt elevator and reflect that tissue. And you can see as I lift this up, then I'm going to get access to the bone. But my goal is not to flap big. So my goal is to flap efficient and have it out of the way, make sure it's nice and clean. But I like to keep the blood supply, which is 30% from the soft tissue, to go to that area. So I don't want to necessarily lift up all the tissue. You have more swelling, more problems, and more pain. But also, I feel that it's just going to be a better healing situation. Now we're going to start the anterior implant using the guided approach. We'll use a 2mm drill, and we'll access this using the ring. And the ring will tell us how deep, what position, and what angle to go at. And as you'll see, is we're able to get a very precise osteotomy started. And when we do this, we're able to measure the tissue. So the 2 millimeters of tissue is just not enough. we want to have at least 3 to 3.5 to even 4 millimeters of tissue. So we don't want to have 2. So we're going to plan this implant to be subcrestal so we can develop more tissue. So we want to base this on the zenith, and so it's a little bit more complicated than we can go through right now. But going in with the second drill, then we can go in and start to make the osteotomy wider. And so we can get this, and even on this area, sometimes I go a little bit deeper because this is soft bone. I want to make sure I can get this osteotomy done. So I'm not going to do the third drill, which would normally be done here, because the bone is a bit soft. And so we'll come back and just place the implant at this point. So the implant is put on the loader, and you can see that when we do this, it's going to carry the implant and allow us to get this into a position. So this has got a tight ultra surface, which is very hemophilic and allows for earlier healing. They feel it's roughened, but it's anodized, which makes it extremely hemophilic. And they put this surface coating on that allows you to get a really good initial day for that implant, because the first day is really important. It's a very traumatic day. And so we'll tighten this implant down and line it up, and you can see here that we're going to get about a 60 Newton torque on this implant, and which is a nice torque in soft bone. So we'll take all this off, and you look at the implant. It's subcrestal by about 1.5 millimeters, and we're going to use a CC bone mill guide to place on the implant, so I can guide the milling of the top of that implant. So you'll notice when we go in, they'll use the CC bone mill and then allow me to shape that top tissue so that the healing abutment will go on no problem, and all the subsequent abutments will also have no problem, because we don't want to have whoever's placing the crown, which will be me here, to have a problem with seating of the abutment. So you see that the implant is ideally placed. It's at the right depth, angle, and position. And now we can start to move on. We don't want to put the healing abutment on yet. We want to wait because we're going to be putting the guide back in. But there's what it looks like. And we've got the ability to get that exactly where we want. So I'll go back, and now I'll use a scalpel 15 blade. And I'm going to flap the posterior, which was where we're going to do the sinus lift. Now I'm going to use the guide to also guide me where I'm going to be on the sinus lift, because we have adjacent teeth. These two teeth, we don't want to disrupt them and hurt them. So we want to go in and be delicate, but at the same time get in and do the job with the piezotome. Because the piezotome is a nice feature of not really destroying the Schneiderian membrane, because when I'm using diamonds or carbide burrs, sometimes you can damage the Schneiderian membrane, which, as you know, is the membrane that has the goblet cells that makes the sinus nice and moist, and also has little cilia that cause the membrane to be moving materials out of your sinus area. So as I flap this, I'm going to raise this up. It's going to raise up pretty quick, but again, I'm trying to be a little bit not too aggressive. However, you have to see what you're doing, and so that the guide will tell me and help me to be in a position right away. Now, I don't want to just take a drill and use the 1.5 drill and go into the sinus, because then you'd perforate the Schneiderian membrane. So I'm leaving these here so you can see these are usually used to position the guide and hold the guide down during the surgery, but we're not doing that here. We're using these two areas to tell us where the roots are and where the sinus lift is. So I'll take those off, cut them off, and now usually I just have the lab cut them off, and so that there's an osteotomy hole. So I'll go to the piezotome, and we'll take that in, and I'm going to put the first preparation burr on, which is vibrational activity. So vibrates with a lot of water to keep it cool, and you're able to then take these tools and allows I'm really going to use the trumpet here, and also I'm going to use the osteotomy, so it kind of goes in and shapes a little round ball. And sorry, I can't remember the exact name of it, but it's an osteoplasty BS62, and so there's the reference number. So going through here is going to allow me to position and make a dimple, and so the dimple is going to the posterior and the anterior. So as I put this in and position it, the teeth are telling me where these two osteotomy points are going to be, because the teeth hold the guide into position, and then I'll place the round osteoplasty burr in and start to mark where the two lateral points of this osteotomy will be. So I know that I'm not going to go in and hit the root and cause a problem, and I also know that I'm up high enough so that I can put the graft in and have it sit into like a bowl effect, and not having it fall out. So as I go in, I'm going to use lots of water, so I'm using some saline here, and this travels down the piezotome. Has a nice light that lights it up as well, so it's got this LED light at the handpiece, and as I go across, I can use my retraction to orient myself so that I can connect those two dots now. So this is the major inferior aspect of my osteotomy, and then I'm going to choose to make the size of the osteotomy bigger. So as I go in, I'm going to cut the bone and get that into position. So anyway, it's a very useful way to use the guide to get yourself positioned. Now as we go through, you can see it's darkening, and there's a little blood vessel there we saw on the original x-ray. And so we know what's going on. So I know exactly where I am. I'm ready for problems if it happens. And the water's cooling it down. And as it gets into the darker area, I'm going to start to switch up and use the trumpet burr, I call it. And so the cube is a really effective tool, because it's not going to go in and tear the Schneiderian membrane, which is one of the worries I always have, because it's very difficult to get in there anyway and not cause problems with it. Some people say in about 30% of the cases that there's little tears in it. So as we see this, we'll go around the most posterior aspect of this, and we're protecting that Schneiderian membrane, which is the key to get this piece of bone moved on the lateral wall of the sinus to allow you to get in and do the placement of the bone. So we'll change and we'll put this burr assembly on. These just screw on top of the handpiece, and so this one is the SL32, and you can see that it's designed to be putting some pressure, and I'm going to use this just to put some lateral wall pressure to do a little bit more fracturing of that little plate. So we're separating that off and trying to be delicate, and this is sometimes difficult because the membrane is not very thick. So the goal of the piezotome in my mind is to get the bone out of the way and get it access and cause as minimal damage as possible. And I think it's a great tool for that, and it's one of those tools that it's invaluable, because sometimes I'm using different techniques over the years, and if the burr just hits it at all, it's causing some perforations that are just not really that great. Then you have to deal with that, which is fine. You have to take courses to learn how to deal with membrane perforations, and but still, the tooling makes a huge difference. So here we're going back in with the trumpet shaped burr. You can see I'm just coming up underneath the side of the sinus, and just having it so that I can push that back a little bit and get access so that I can start to do the bone grafting part. And so here we're just getting underneath and just separate. We know that like in these areas where there's roots around, it's a little bit more difficult to do the sinus lift in my opinion, but some people would say the opposite. But the area is not that big, you have to be careful. So this tool is quite amazing to do that. And you can see the Schneiderian membrane is fully intact there. So we come back, we want to remove the other piece of bone. But I know exactly where the roots are because I'm on the other side of the patient here. I'm a lefty. And I find doing the sinus lift on the opposite side is more difficult to know where you are in a 3D positioning. So doing a guided approach is helpful. But on the guided approach, you do have to make sure that you try to get the digital scan as high as possible. You could even take, a model, like take a PVS impression and then scan the impression, because you're going to get then a static position of the side of the sinus. So sometimes I'll do that too. Now I'll cut the membrane, you can see there on the corners, to make it like a parachute. And then when we put this in, we're going to put it into a position that allows for it to help to separate the bone. So we're just tidying this up a little bit more. I'm going to take some of the bone away from the, the bone has grown here. And you can see that there's some excess. So we're going to take some of those particles and place it into the graft just to act as some nidus for the grafting to grow. But most things grow. Carl Misch, when I took courses from him, he always said you could put anything in there, it's going to turn into bone. And it's I learned a lot from Dr. Misch. And anyway, he thought that this was something that was a very useful technique, and learned a lot from Dr. Michael Picos as well. So you can see here that if you look at this now, we've we're ready for the bone grafting procedure. I'll just make sure that the membrane is able to not have adhesions, and so that the bone will get to the anterior, because this is more the difficult area to have the bone. This is a fairly tight bone graft procedure, so it's not, I don't have to go too far anterior because the root's right there. And we'll take some bone graft. So we're going to mix some Creos bone grafting material. We use a collagen membrane, and this membrane I'm going to cut in 2 pieces because it's such a big piece. And you can see I'm just using gloves here to show this after the surgery, so I'm not doing this during the surgery. But we'll take this and we'll show that. So we're going to open up that membrane, cut it in 2, and then cut the corners a little bit. And you can see the corners are cut here. And when we are doing this, then we'll slide this into position. So if you had a perforation, this would help to protect you against the perforation. I do like to put the more roughened surface towards the sinus. I don't know, I've asked the question many times, and people say it doesn't really matter which side you put it in, but I want to have that roughened up against the lateral Schneiderian membrane so that it will actually help keep the bone into position. So the goal is to keep the bone out of the ostium and avoid the osteomedial complex. Now we're going to use some allograft here and also some xenograft. So we'll mix this in a 50-50 mix. And the allograft, you can see, comes in its own little packaging. And then we have the Xenoprotect here. So you just buy both of these, mix them together. So 1 cc of both of them. You don't necessarily have to use the whole part, but it's a 50-50 mix with some saline. You can also get into mixing blood product in there, but so far I'm just doing it this way. So as we put the bone in, we don't want that bone to get to the ostium, so we want to have that so it's sandwiched in and protected for the patient's purpose. So it's going to lift that piece of collagen up, and the bone is going to be put in laterally and anteriorly first, and then into the posterior after. So then we'll take the other part of the membrane, and we're going to lay this on the buccal, on the bone itself, and we'll use a couple tacks just to tack it down so we can get some sutures in and get this to heal. And this is going to allow the patient to then heal for 5 months before we can start to place the implant. So it's something that the patient's going to have some. We also, of course, want to score the perosteum. We didn't take an image of that, but you take the scalpel and just cut it so that you're not going to have a major contraction, but you're not really adding to the bone buccally, so you're not going to have as much contraction on this procedure. So we'll take some tacks, and the tacks are going to hold the membrane. So here I'm just going to put 2 tacks in, and then put the suturing in. And you can see that I'm going to come in and place 1 tack in one direction, another tack in another direction. So just to keep it into position for the patient, so it's not moving around a lot, and which will stop and impede the healing for this area. So I don't have to go into major tacks here. This usually works quite fine. So as we come in, we'll put a tack on closer to the ridge itself, and I'll take that tack out when I go to place the implant. Now we'll use a non-resorbable suture and take these out 2 to 3 weeks after the surgery. So this has been Dr. Scott MacLean. Hopefully this will help you, and be sure to take a course and do lots of practicing, and this is more informational for you just to be able to talk about it. And anyway, I hope you enjoyed it, and here's our final x-ray. We can see the anterior implant, we can see the sinus graft. So this is Dr. Scott MacLean, and this has been a video about implant dentistry.